This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best.
Okay, welcome to the Nupsala podcast. I'm Greg McGarrell, and today I am joined by Dr Bowen, a specialist in equine internal medicine. Mark has been using a unique biologic approach to the treatment of equine asthma, so we're going to find out all about it and what benefits this treatment has over conventional medicine. Mark, good to have you today.
Good to see you, Greg.
Okay, Mark, just for the audience, do you want to just give a little bit of background as to who you are and why you are here today and leading up to it very quickly?
I'm an equine internal medicine working in the East Midlands. I have a private consultancy business where we provide specialist care to horses on the yard or within the clinic. So we go to the horse or to your clinic to help you with challenging cases. We bring all the kit with us and the expertise to help you get your job done.
Great. Okay, Mark, let's get straight to it. Equine asthma, that's the term we're using today. How do we get to the term equine asthma? Where does it come from and what does it encompass? Everything.
It covers everything. So as you say, it's a relatively new term, came out of a consensus statement 5 to 10 years ago that actually equine asthma was closest to asthma than it was to any other condition. So the very old term of chronic obstructive pulmonary disease is a disease of smokers, and we moved away from that because we wanted to differentiate it from smokers' lungs. So we came up with the term asthma, and we have two versions of asthma that are trying to replicate what we used to define as inflammatory airway disease of the young horse and of recurrent airway obstruction of the older horse. And they're likely a continuum. They're the same disease, just affecting different horses to different severity. And the point with that is inflammation is at the heart of disease. So we used to focus our treatments on bronchodilators, things like clenbuterol. We've moved from that. Now we are using corticosteroids a lot more, and this is where the idea of moving to biologicals has come from.
Yeah. I'm asthmatic myself. So, yeah, I know all about it. I've had asthma since childhood. That whole sort of blue inhaler versus the steroid inhaler and how we're trying to get off the blue, because that's not the way you should be managing the disease. And I suppose that's the same as using the bronchodilators, the clenbuterols and stuff as your main product. Same way we're getting the advice that's not the way of managing the disease. It's a symptom reliever, and we're not managing it by using a symptom reliever. We've got to get to the heart of the problem, haven't we, really? The disease itself.
Exactly, and it's worse in people because beta-2 agonists have been associated with sudden death. We don't think that's a problem in horses, but all you're doing with bronchodilators is opening up airways or trying to open up airways even that are constricted because of inflammation. So you're coming at it from the wrong angle. Now, they still have a place in that emergency situation, that initial management. You want to improve the clinical signs rapidly, or you're presented with the horse that can't breathe. But even in that acute stage, we tend to be looking at the parasympathetic. So things like hyoscine that will block the bronchoconstriction pathway at source, rather than using beta-2 agonists, even though they are the authorised treatment for the management of acute crisis.
So getting back to the patient, I mean, do we find a certain equine population are more prevalent to this? Are we talking the indoor pony, barn, cobwebs everywhere? Or are we seeing performance horses or across the board? Where do we see the spikes these days in horses having respiratory disease or equine asthma? Sorry.
I think you're absolutely right to call out that change, because that very classic presentation, the pony and the hopelessly ventilated barn, that was where we used to think of this condition, but people have moved on. We don't see that as often now, so it tends to be a subclinical disease that's affecting the performance horse more than anything, and that's where we see the challenges, because actually bronchodilators won't even help those very much, because it's the inflammation that brings together all the mucus that means their airways aren't working as well.
Yeah. Okay, so it's a subtle disease, can affect the performance horse, can be managed as a disease,
Yep.
but now we're in the realms of drug, performance horse. Can you compete on a drug that is managing a respiratory disease?
Absolutely. That's the challenge, and that's why we're looking at what else we can do. So people have been looking at drug-free treatments for a long time, and the classic was using inhaled saline. Now that's come from human medicine, that actually they use that for the treatment of cystic fibrosis, that you get a patient to inhale saline, that brings fluid into the lungs, they cough that up, and with coughing it up goes all the inflammatory cells and mediators. So that does still has a place in the competition horse, but it's still not really addressing the problem, which is that inflammation.
So it's not disease management yet. Okay. Do we have a disease management protocol or treatment regime?
So corticosteroids are our mainstay of therapy, and we would traditionally use those corticosteroids either as a tablet or a powdered form, or we would use inhaled human medications.
Okay.
There was, as many people will know, there was a really good version of cyclosinide that could be given through a equine specific mask, but that product sadly has been withdrawn from the market. But even that had a 72-hour detection time, so you wouldn't be able to use it within several days of competition.
So coming off that, the disease kind of builds itself back up again, and we've got respiratory distress.
Yeah, exactly.
And the inflammation comes back.
The inflammation comes back. And what you hope is, in an ideal world, you fix the inflammation and it goes away and never comes back again. But that's
no outcome.
Not going to happen.
Yeah, okay. All right, so where does biologics fit in? How is this now coming about?
So you're obviously a company that worked with biologics for a long time. So the way I got introduced to biologics was by a human respiratory nurse who is a horse owner, and she approached me about a novel product that she had heard about, which is a replacement for corticosteroids.
Right. So using the biologic then, it's counteracting the inflammation?
That's the way that I now sell it to clients. This is a biological form of a corticosteroid, if you like. So it's not a steroid, but it has the same anti-inflammatory properties, but it's a natural material. It comes from the horse's own blood. It's therefore not doping. It's not detectable. Yeah.
I suppose we don't look at biologics the same way we look at pharmaceuticals that have been proven to have an anti-inflammatory effect. And I guess for the audience, do we know how the biologics are working 100%? No, would be the answer to that.
I was looking at you there for some answers. What are you asking me? This is so we don't know all of the mechanisms. How these work.
What we do know is a lot of the biologics, whether they're containing, anti-inflammatory cytokines or different cell sources, is that the body is using them as cues. So how they're using them, the length of time it's using them. What we do know with the biologic, especially an autologous one, is it'll start with it will do no harm.
Yeah.
But if we are seeing a symptom relief, I think it's too far to go today to say that it's a disease modifier. Although some biologics are seen as disease modification, so that would put it into the bracket of disease management. But if we are seeing it as at least a symptom modifier, I think that's where we start today. And symptom modifier, especially in respiratory disease, I look to you now, you are seeing the physical evidence of a symptom modifier if it's not on any other drug.
Exactly.
Which is different to using in joints and other places where you cannot see the difference. We can put a biological into the joint and, you don't really get to see it. But with respiratory disease, it's probably one of those diseases that it's very obvious if something is working or not.
Exactly, because you will see an improvement in performance, and if it's a more severe form of asthma, you'll see their coughing stopping, and that's what we're seeing. We're seeing an improvement in clinical signs, which means we've got a drug that we can use or a drug replacement that we can use in competition horses. We've also got a product that we can use where we are concerned about drug-induced laminitis. And okay, the evidence is that laminitis is not induced by corticosteroids, but we've all seen cases where they might have been on the edge and they get tipped over that edge into crippling laminitis, but with the use of systemic steroids.
I mean, I've certainly seen in my time the use of biologics that can also allow a clinician to reduce the dependency on a pharmaceutical. I'm not saying completely cut it out, but we might reduce the dose or reduce the interval dose. Is that something that's also come to mind?
Yes, absolutely. So some cases they will still have use of inhalers on an occasional basis. So they'll use them when they're challenged, maybe going to a competition. On the way back, they might give them some inhaled steroids at that point. But largely, these are clients who want to have their horses steroid free.
Yeah. And any complications, do you think, at the moment, or have you seen with biologics?
I've not seen any complications. And it would be difficult to understand how you would get complications given what we're administering in many ways. Now, we are giving, as you say, a bunch of potentially cytokines, and those are but they are the products that people are looking at. Can we block the inflammatory cascade by blocking specific things? Yes, we are still taking that slightly broad approach, but the broad approach probably is more effective than trying to knock out single mediators.
I mean, I say that because there may be listeners who, in their experience of biologics, have seen an inflammatory response, and we're treating an inflammatory condition. They might be worried that they could double up on this.
That's not something that we've seen in the horses that we've treated, and I'm not aware that that's been reported in any of the other cases where it's been used either. And we aren't in the sterile environment of a joint. We are in the lungs, which are dirty and full of all sorts of muck.
Yeah. Okay. So, I mean, how do we deliver this biologic of choice, or any biologic that you're going to use to treat a respiratory condition with? So
the brilliant thing about this product is it's delivered through a nebulizer. Now, many of the clients have already got nebulizers because they've been using inhaled medication, so they understand how to use them, they understand the process, and then it is just swapping what they're using. And it's something that you use on a weekly or monthly basis.
And is there a grading system where you would grade an asthma, like other conditions, and this would fall into lower grades, or could it be used in a more, serious or chronic condition?
So there is a grading system. So there's a weighted clinical scoring system that we try and use whenever we use this product. And we do that ourselves. It's looking at clinical signs. It's looking at how heavy they are. It's looking at how much they're coughing. So it's a structured way to get clinical history and assess that horse, so we can then look to see, are we improving? And we probably see, in reality, the biggest effect is always going to be in the most severely affected horses. And those are the data that are going to excite people. If we take a horse from a high weighted clinical score to a low weighted clinical score, that's exciting and it's cool. But actually what horse owners want is to be able to take their horse that's relatively well controlled and keep that off drugs.
Okay. So, trying to get my head around it, we've got a more stabilised patient rather than a destabilised patient, which is the target for this. You're still dealing with conventional medicine to stabilise the patient.
That's what I'm doing at the moment.
Yeah.
Yes,
Okay.
That would be my approach. Is we start them on a course of corticosteroids, and that might be inhaled or injected, or even orally, and then we'll transition them on to using a biological to maintain control of medication.
Great. So it's that stabilised to management phase. They're on the management phase, probably receiving the biologics and assessing.
The place I found it really helpful, though, were the summer-associated cases. So what we didn't talk about was triggers for asthma. So asthma, as you talked about, it's typically out in a dusty barn environment with lots of cobwebs. The challenging cases are the pasture-associated cases. So they still have airway inflammation, they still have the same endpoint, but what they have is a different trigger, and those triggers are in the environment. So you can't just turn them out and they're going to get better, they're going to get worse. And so what I really want to do with these cases is start their course of treatment before the grazing season, before the pollen season starts, and then hopefully we can treat them through the grazing season with one course of treatment that will last them the 6 months when they're most at risk, and then through the winter they will probably not need medication at all.
Going back to the performance horse for a second. EIPH.
Yeah,
that's a tricky one. But I mean, somebody might be thinking about it, listening to this. Could we? I mean, I don't know if it could at the beginning, but it's a hell of a challenge to go after.
Yeah, so EIPH is such a complex condition. I mean, there's so many causes of asthma. We get to EIPH, we don't all agree what the actual trigger is. So it's one of those things, it might play a role. There is certainly an inflammatory component to EIPH. We know horses with mild asthma are more prone to getting EIPH. So it might give us part of the answer.
Yeah. Almost it won't do any harm, but we can't promise anything if people are thinking at the moment that EIPH could be a target for this type of therapy. No,
but we do know that anti-inflammatory avenues are sometimes effective. But there's no... The problem with EIPH, there's no single cure for it. So we can't say it will always work. It might work in some cases, it might not work in any. We just don't know at the moment.
Okay. All right, so getting back to our good old traditional asthma barn-kept pony, not necessarily just that, is there a case that comes to mind that you thought this may or may not have been worthwhile doing or challenging, but the results of using this as a biologic clearly demonstrated to you that you were certainly on the right track with that choice of treatment?
Yes, so one case that I've had, they've tried many other treatments. That they had tried inhaled steroids, they had tried the normal clenbuterol as a treatment, and that was the only thing that was, if you like, managing. But as we've talked about, that's a rescue treatment. That's not a sustainable long-term treatment. And for whatever reason, corticosteroids just weren't touching this horse. Now, there's lots of reasons why that might be the case. They were using inhaled steroids through a nebulizer, and we transitioned to using a biological through exactly the same nebulizer. So it shouldn't be a delivery problem, but it might just be that it has different mechanisms that are outside the traditional arachidonic acid mediated pathway of inflammation.
Yeah. And how long ago was that case?
That was last summer.
Last summer. And where is it now as far as its disease management?
So its disease management, it is still doing really well, and it has not yet had to start a second course of treatment. So we've treated it through last summer, and its signs are currently in remission.
Right. So not on any other medication?
Not on any other medication.
That's interesting.
Yeah. That is interesting.
I'm not going anywhere near disease modification at this point in time, but that's interesting. It hasn't. So coming into the summer and all those triggers are still not triggering it right now?
Not triggering it right now. Now, every summer's different.
Yeah, true.
And so who knows? It might get to the point where it will need treatment later on.
Yeah. And
that's what we've planned with the client. It would have a second course of treatment each summer.
Okay. Okay, so I think really sort of summarising today, the biologic of choice, it's the A2M molecule that we're all talking about here. It's relatively new to us, to everybody at use. I can't say that we know everything about how this molecule is working. There are some publications, more in human than there is in veterinary. It's always a challenge in veterinary, as to how the A2M molecule works. We know the A2M molecule it's an autogenous molecule. We all have it. It has a role in fighting inflammation. I suppose the way that we are targeting it for equine asthma is not too dissimilar to the way that we're targeting it in joint disease, is that we are removing the patient's blood, we're processing it, concentrating that molecule, which I suppose in a circulating volume it's not that high, and all we're doing is goes back to how we've used biologics for the last 20 years. We're taking a concentration of it and delivering it to the area of disease so that it can do its job, where I suppose a circulating cell or a circulating molecule will always find it hard to combat a disease of this nature, of any inflammatory disease, I suppose. So here we are, we're using the A2M molecule. It's early days. Yep. We've still got quite a lot to figure out. But I suppose in summary, could you identify the target patient that you would use an A2M molecule biologic on today? So
at the moment, my target choice would be the summer-associated cases of asthma. That seems to be there's two reasons for that. They're the most challenging to treat, and this is a novel approach, so it gives us something different to try. But there will be traditional asthmatic cases, the winter-associated cases, that will still benefit from this. And in those horses, it's about targeting the performance horse largely, but it doesn't have to be. And as I say, treating horses that are at risk of laminitis with steroids still scares all of us, whatever the literature says.
Okay, so that's one end of the spectrum. Which horse would we steer clear of using this on? So I've alluded to this already. I am currently not using it into those very severely affected cases. Now, if it works, that's where we're going to see the greatest numeric benefit in terms of outcome. So in some ways, that's where we should be targeting it to see how well it works. But for me, understanding the disease process, I want them to have a degree of control over their inflammatory pathways before we start giving them other natural anti-inflammatories. And studies to back this up, I understand there is some studies out of the US at the moment. Have you seen sight of those?
Yeah, so there's some studies coming out of the US that support the use of this product. I mean, I think the interesting thing is we start with a product that was developed for managing joint disease. We're going into lungs, and people are looking at other places they can use this product.
Have you seen sight of those studies, or you're waiting for the publication?
I'm waiting for the publication.
Okay, all right. I suppose when the publications are out, we'll certainly share them with everybody. We'll probably tag it on to this podcast for future reading as and when people listen to this and want to look into it a lot further. Okay. So, Mark, that's been a really interesting summary on the use of the A2M molecule for equine asthma. It's a start for 10 for a lot of people. It's something to consider. I suppose if people have got questions, as long as they don't inundate you, are you open to have those questions or
very
referral?
So. Yep, absolutely. We're always available for advice. And
you heard it here, everybody. Go straight to Mark.
All my colleagues.
Okay, and I hope you've enjoyed listening to this. And it is interesting how we evolve in veterinary medicine and how we take things forward. Rationale is always there, and we try to practice evidence-based medicine, and we do, and that little bit of confidence leads to a bit more competence, and let's take it from here. But thank you very much for today, and I look forward to learning a little bit more about it.
Thank you very much.
Thanks for tuning in to the Nupsala podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts and Amazon Music. Simply search the Nupsala podcast. You can also watch on YouTube or directly at nupsala-learning.co.uk. If you'd like to stay up to date with all our latest content, please follow us on social media, where we always post when a new episode launches. All the links and details are in the bio. Thank you.